Hi everyone, my name is Gurjot Basra and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. And I'm pleased to welcome you all to today's session on CLL/SLL. We appreciate those who have been able to join us live today to learn more about the disease-specific biology of CLL/SLL, as well as novel treatment options available for Canadians. So before I introduce the speaker, I just wanted to provide some guidance about the Zoom software for the session. So this virtual software does not allow you to share your video or turn on your microphone. Hence, if you do have a question, please save it for the Indolent Lymphomas Q&A session that will follow this presentation. So without further ado, to introduce our speaker, today we have here Dr. Alina Gary, who is a hematologist and assistant professor in the divisions of hematology and medical oncology at the University of British Columbia. She is a member of the Lymphoma Tumor Group at BC Cancer and a clinician investigator with the Center for Lymphoid Cancer at the BC Cancer Research Centre. Dr. Gary is involved in translational, clinical trial, and outcome-based research related to leukemia and lymphoma. Other academic interests include the investigation of novel therapeutics and stem cell transplant for CLL and lymphoma, and improving long-term outcomes for lymphoma and stem cell transplant survivors. So thank you so much, Dr. Gary, for joining us today, and I'll hand it over to you.
Great. Thank you very much for that kind introduction. I'm really delighted to be here today to talk to everyone about CLL/SLL. We're going to go right from diagnosis through to treatment. I'm coming to you from Vancouver, which is on the beautiful unceded and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And without further ado, I will begin. Here are my disclosures. I have received institutional research funding and participated in advisory boards and received honoraria from the companies listed here, primarily related to CLL research and drug development. In terms of an outline, we're going to touch on a number of things in the next 45 minutes. First, we'll talk about how CLL is diagnosed. What are prognostic tests and what do they mean? What is active surveillance? I'm sure this is a term some of you have heard before. And then we're going to really go into an introduction to CLL treatment. And I'll talk about the drugs available now currently in Canada for CLL and SLL. Review time-limited therapy and the use of something called MRD to guide therapy. Talk about some of the drugs that are in development, including one example of a non-covalent BTK inhibitor. And then just briefly touched on immunotherapy, a very exciting new avenue of research. And finally, at the end, I will discuss Richter's transformation. Again, this is another area where the research is really expanding in this area, as it truly is an unmet need at this point with CLL. So I'm going to talk about a typical CLL story, and this may sound somewhat familiar to some of you, based on your own experiences. This is based off a current patient of mine. So this gentleman is a 66-year-old man. He's an avid runner. This is a picture of him doing the Sun Run in Vancouver. He developed knee pain related to his running, and so went to his family physician, and just a very routine physical exam was done and routine blood work. So they did order something called the CBC, and all of a sudden, out of the blue, he was told he has leukemia. So I can imagine how, devastating, confusing, anxiety-provoking being told this could be for somebody. So I hope in the next 45 minutes, we can try to untangle some of this a little bit and understand this a little bit more to provide more clarity and more reassurance. But before we try to understand leukemia or CLL, it's first important for us to understand our blood counts, and in particularly something called the CBC, or a complete blood count. So just like wine, there are 3 different types of main blood cells: red, white, and rosé. So red blood cells carry oxygen around the body, and if they're low, they cause anemia, where usually people have fatigue, low energy, they might look a bit pale. Then we have our white blood cells, whose usual job is to fight bacteria and viruses. These are a very important part of our immune system, and if they're low, people get infections. And just like white wine, we have many different types of white blood cells. And the most important ones for us here in understanding CLL are the lymphocytes. We actually can have B lymphocytes, B cells, and T lymphocytes, T cells. Neutrophils are another kind of white blood cell that are very important and something that we really pay attention to when looking at the CBC. And then there's other white blood cells. If you ever look at your own reports, you will see some of these names mentioned: monocytes, basophils, eosinophils. They're important parts of our immune system, of less importance when we look at the actual numbers on a report. And then finally, for row A, we have platelets, which coincidentally under a microscope do look a little bit pink or purplish. These are vitally important to help our blood clot. So if people have low platelet counts, they can have bleeding and bruising. So CLL is a cancer of one of those types of white blood cells, specifically the B lymphocytes. It's a slow-growing cancer, so we say that it's chronic, just like other chronic diseases like diabetes or high blood pressure. And usually it's discovered when it's noted that someone has a high lymphocyte count in the blood. So our normal lymphocyte count is somewhere between 0.8 and 5. And people with CLL will have a count higher than 5, so it could be 6, but all the way to 100, but even 200, 300. I think the highest CLL white blood cell count I've seen is around 700. So it can get very, very high. And what happens is these abnormal cancer cells, CLL cells, start to crowd out the normal healthy blood cells. So people end up having low red blood cells, which causes symptoms of anemia, and low platelets, which causes bleeding and bruising. And here you can see a picture within the healthy blood where it's primarily red blood cells with a few scattered kind of pink and purple cells. Those are the white blood cells. The platelets in this picture are actually in yellow. And then you can see the CLL blood where there's fewer red blood cells. So this person would have anemia, and it's sort of packed with the white blood cells, the pink and purple cells. So how do we diagnose this? It's diagnosed very easily on the blood. And this is why kind of on routine blood tests, people often go in for something completely different and can be suddenly told they have CLL because this test was done in the background. So it's done by a test called flow cytometry. And what this is where the blood cells get put through this kind of single tube, and then a laser light source gets shone onto the cells in the tube. And depending what surface markers are on the cell, the light will scatter in different directions. And this can help the pathologists or the scientists in the lab determine what kind of cells those are. So flow cytometry helps us classify cells in the blood based on markers on the cell surface. And in this case, they look for specific markers that are seen in CLL cells. And in particular, we look for markers called CD19 and CD5. So this is a very easy way for us to diagnose CLL just from a simple blood test. Now, sometimes people do require a bone marrow aspiration and biopsy. It's not usually required at diagnosis, although it can be in certain scenarios. And it may be needed prior to starting treatment or at the end of treatment to assess how well someone's responded to treatment. So some of you may have had bone marrow or heard of this test. Essentially, people either lie on their stomachs or on their side, and we take a tiny little sample from the actual bone. We take the fluid or blood that runs through the marrow, and then a tiny little sample of the bone itself. So it is a very important test for us in certain points in people's journey, but not always required. It really depends on the situation. So what about small lymphocytic lymphoma? So this is where you have the abnormal B lymphocyte, but they're in the lymph nodes or organs instead of the blood. And in people with SLL, their white blood cell count is actually normal. SLL is considered an indolent or low grade, again, kind of chronic lymphoma. And usually people end up having enlarged lymph nodes that they can see or enlarged organs that maybe they have symptoms from. Usually it's the liver or the spleen. Now you can see from the picture, we have lymph nodes all throughout our body. The main ones that people can feel are the ones in the neck, under the arms, and in the sort of groin region. And to diagnose small lymphocytic lymphoma, we do need an actual lymph node biopsy or a tissue biopsy if there's a mass somewhere else. And more frequently, we use CT scans and PET scans to help determine where in the body all the lymph nodes are enlarged. Now, patients with CLL will also have enlarged lymph nodes, but the key is that with CLL, they have the high lymphocyte count in the blood, whereas in SLL, there's no high lymphocyte count in the blood. But it's the same cancer cells, those B lymphocytes, that are causing the cancer. So now we'll go on to prognostic testing, and we have two main kinds done using what's called cytogenetics, which is looking at chromosomes, and using genomics, which is actually looking at DNA. Chromosomes are made up of DNA, but it's just two different ways to do different prognostic tests. So these tests usually are not required at diagnosis, although it can provide useful information. But they are typically done at least prior to starting treatment because they definitely help us guide therapy. So the first main prognostic test that has been around for a long time is looking at what we call cytogenetic abnormalities by a test called FISH. And we look for four main abnormalities. Deletion 13q, which actually means deletion of part of chromosome 13, trisomy 12, deletion 11q, and deletion 17p. And over studies done many, many years ago with patients who received chemotherapy for CLL, they were able to show that people who had a deletion 13q actually did the best, so have what we call a good prognosis, and patients who had deletion 17p did the worst, so had a worse prognosis. Since then, though, we've been able to use DNA sequencing, which is called genomics, to do a number of other prognostic tests. The main one that we talk about is something called IGHV mutational status. IGHV stands for a long term. It's called immunoglobulin heavy chain variable region mutation status. Doesn't really matter the long term, we just call it IGHV mutation status. And what it's referring to is a person's immunoglobulins. So immunoglobulins are actually our antibodies. We all make antibodies. It's actually our normal B cells that make antibodies. And in the normal part of development of antibodies, they actually mutate. And this is a good thing. We want them to mutate. So people who have a mutated IGHV status have a better prognosis. And people who have an unmutated IGHV status tend to have a slightly worse prognosis, particularly with chemotherapy. But it's split about half-half. This particular test sort of divides CLL patients into two main groups, mutated IGHV and unmutated IGHV. There are then a number of other tests, things called TP53 mutation testing, karyotyping, and looking at gene panels. These are not all available in all centers, and we're really beginning to learn the importance of some of the latter ones. TP53 mutation testing is important and hopefully is coming in most Canadian centers in the coming months to years. And then karyotyping and gene panels are a bit more complex, and we're still sort of learning about those. So what do we really mean? When we say good prognosis, what I mean is that people with good prognosis CLL, we know will respond really well to treatment, particularly chemotherapy. So that's generally deletion 13q and mutated IGHV. People who have poorer prognosis don't respond as well to chemotherapy, and that's generally deletion 17p and unmutated IGHV. And with deletion 17p, we also know that even with the newer drugs we have, they respond very well, but just not as well as people who don't have deletion 17p. So it's still a high risk feature. And now with all of the new drugs that we have, as I mentioned, we're kind of re-looking at all these prognostic markers and looking at new ones like complex karyotyping and further gene panels to really try to figure out who does well, can we predict who's going to do well, and with our current therapies. But this is really evolving over time. So CLL and SLL are really the spectrum of the same illness. People can develop symptoms like fatigue, they can look pale from anemia, have some shortness of breath, they could develop weight loss, bleeding and bruising, as I mentioned, develop infections, because although their white blood cell count might be high, they're abnormal, they're cancerous white blood cells, they're not working properly. People can get night sweats. We already talked about swollen lymph nodes and spleen. But a lot of people actually have no symptoms, like our gentleman here. And this is what we call asymptomatic. So our goals of CLL and SLL treatment we have two main goals. Firstly, to prolong survival. We want to give treatment that we know is going to help prolong survival. Ideally, the goal is to have a normal lifespan as if you didn't have CLL or SLL. But at the same time, we also want to make sure people have a good quality of life. We don't want to give lots and lots of chemotherapy that makes people very, very sick if it's not going to improve their overall survival, but also considering their quality of life. So CLL is incurable as of today. And I put today in brackets because we're hoping for a cure. There is a lot of research ongoing to really try to find that cure for CLL. But as it stands now, it is currently incurable. A lot of studies have shown that early treatment does not prolong survival and can actually worsen quality of life due to side effects. In addition, there's concern people could develop resistance to drugs and then wouldn't be able to use them when their disease actually progresses. So as of today, all current guidelines sort of around the world, including in Canada, recommend something we call active surveillance for patients who don't have any symptoms. So what do we mean by active surveillance? There's lots of different names this has been given. Watch and wait is a very common term that's used, observation, monitoring, but I also know that a lot of people think of this as watch and worry, doing nothing. And this period of time can certainly lead to a lot of anxiety, sadness, fear. People tell me that they feel that their life is on hold, they can't plan for the future. So I understand that this can be a very worrying time for people. But I want to assure you that it's not that we're doing nothing during active surveillance. Active surveillance is actually a really great time to focus on other things to get oneself in the best health possible for if and when the disease progresses to the point that treatment is needed. So what do we really mean? Usually we review patients by a medical professional somewhere between every 3 to 12 months, and that just depends on a number of factors. Patients will usually get a CBC, we'll take a history asking for all of those symptoms that I've mentioned, perform a physical exam, looking for lymph nodes in those areas we can feel them, like the neck, arms, and groin. We're also monitoring the lymphocyte count. We know that if it starts to double in about a 6-month time frame, that can represent a bit more fast-growing disease, and usually people will need treatment at that point. But really, active surveillance is a time to focus on a healthy lifestyle. Things like exercise, which we know is really important for all types of cancers to help improve outcomes. Nutrition, just really eating a balanced diet. There's no specific CLL diet, but really wanting people to just have a balance of fruits, vegetables, fiber, sort of in line with our Canada Food Guide. This is a time to focus on mental health as needed. There's a number of CLL patient support groups out there, including such as Lymphoma Canada, where a lot of resources and help can be accessed. And then really importantly is preventative medicine, including screening for other kinds of cancers. Unfortunately, we do know people with CLL and SLL have a slight increased risk of developing other kinds of cancers down the road. So we just want to make sure that they don't get missed for routine cancer screening based on age. So that's things like mammograms, pap tests for women, colon cancer screening, so stool tests or colonoscopies, wearing sunscreen when outdoors to prevent skin cancers, which can be a higher risk for people with CLL. And then, of course, trying to cut back or not smoking. And now we're also learning more about the importance of alcohol in cancer. So just moderate alcohol intake. And then finally, in terms of preventative medicine, this is a really great time to get caught up on immunizations. The immunizations we recommend that people have, because people with CLL, their immune systems can be low, and they can be at increased risk of infections or worse disease if they get those infections. So anything that we can prevent, we really want to do so. So that includes annual flu vaccines, keeping up with COVID vaccines and boosters as they're recommended. We do recommend people get a pneumococcal, so pneumonia vaccine. And it's also a good time to get a Shingrix vaccine. That's an inactivated shingles vaccine to try to prevent shingles. And these things can take time, actually. For example, the shingles vaccine can take, you get one dose and then a booster 2 months later. So during this active surveillance, this is really a good time to get these things done. And then, of course, if symptoms appear, treatment will be considered. So we have a number of different CLL and SLL treatment types. We have chemotherapy. We have something called monoclonal antibodies. We have targeted therapy. So the difference here is chemotherapy is really very strong treatment given through the IV that kills all rapidly dividing cells in the body. So it will kill cancer cells, but it also kills hair cells, for example, cells in the lining of the mouth, which can cause mouth sores. It's part of what leads to nausea. So what all of the new research now is looking into are targeted therapies, specifically treatments that actually target the specific cancer. So we now are very lucky. We have a number of targeted therapies for CLL. And then we're getting into an era of immunotherapy. And the premise here is essentially activating someone's own immune system to kill their cancer cells. So in this case, activating the immune system to kill the CLL or SLL. We occasionally use stem cell transplant for CLL, and the caveat here is that allogeneic, which is a type of stem cell transplant, allogeneic stem cell transplant, is actually a potentially curative treatment for CLL, SLL, but it does come with a lot of side effects, so it has to very much be balanced. It's only done in certain scenarios. And radiation treatment is used for a lot of lymphomas. It's very rarely used for CLL, SLL, maybe occasionally for SLL, but very infrequently. So monoclonal antibodies, particularly in CLL that we use, these are actually a type of targeted therapy. The main ones we use are rituximab and the newer version of rituximab, which is called obinutuzumab. So here's a picture of the antibody, and it is attaching to a marker on a CLL cell. This marker is called CD20. And what it does is it grabs onto that CLL cell and then clears it from the system, basically kills the cell. So we know that rituximab and obinutuzumab can prolong survival when added to chemotherapy. And we also know that they, in particular, obinutuzumab can deepen the responses with the novel drugs that we have. The downsides of treatment are that these can cause infusion reactions. So we have to often give medicine to prevent these kinds of reactions. And they do suppress the immune system, and in particular can lead to a decreased vaccine response. And so that's why it's really important to get all those vaccines before people need treatment with rituximab and obinutuzumab. So now onto the targeted new drugs for CLL. We are so fortunate that we have so many choices for CLL now. And there really has been an explosion of research into these drugs. And all of these drugs target pathways in B cell development. So BTK stands for Bruton's tyrosine kinase, and this is a protein that helps B cells grow. And so by blocking it, we effectively kill B cells and kill the CLL cells. So the first version of a BTK inhibitor that was developed is called ibrutinib or Imbruvica. And that has completely changed the landscape of treatment for CLL. Patients do extremely well with ibrutinib, including the patients with the high-risk features like deletion 17p or unmutated IGHV. But ibrutinib does have a number of side effects, and so newer versions have been developed, and we're now into the second-generation BTK inhibitors like acalabrutinib and zanubrutinib. And then, around the same time as ibrutinib was developed, another class of drugs called BCL2 inhibitors, which are also really important in B cell development, BCL2, was developed, and that's called venetoclax. There's also something called idelalisib, which is a PI3 kinase inhibitor. Again, part of PI3 kinase is very important in B cell development. This drug has a lot of side effects and pretty negative side effects, and so it's actually not used very much anymore. And now there is so much drug discovery and drug development into new ways to target CLL cells. And one example I'll talk about is something called pirtobrutinib, which is a new form of a BTK inhibitor. This time it is reversible. So when it binds to BTK, instead of just binding and staying bound the whole time, it binds and comes off, binds and comes off. And because of that, it's thought to not develop as much resistance. So with all these choices, how do we choose? This is sort of where the field is heading. And part of that has to do with side effects. So if we look at these BTK inhibitors, as I mentioned, ibrutinib was the first generation, and then we have acalabrutinib and zanubrutinib, which are second generation. These circles and all the little dots in the circles represent different proteins in the body, different kinases. And the red dots are where that particular drug blocks. So BTK sits right there. And you can see that acalabrutinib primarily blocks BTK, but it also blocks some other proteins that you see in red there. And if we compare that to ibrutinib, for example, ibrutinib blocks BTK, but we also see lots of other red dots for lots of other things that it's blocking. And this is what leads to all the other side effects of ibrutinib. So we know that it actually blocks parts of cells in the heart. And that's why ibrutinib has some cardiac or heart side effects, including development of high blood pressure and arrhythmias or abnormal heart rhythms like atrial fibrillation. It also blocks parts of our platelets, and this is what can lead to increased risk of bleeding. So you can see that ibrutinib blocks a number of different things. Acalabrutinib is more selective to BTK, and zanubrutinib is probably somewhere in the middle. Although it does look like it has a lot of red, it actually has much less side effects than ibrutinib. And both acalabrutinib and zanubrutinib have been compared head-to-head with ibrutinib in different clinical trials and have shown either equivalent or possibly slightly better results, efficacy, and also less side effects. So as mentioned, these different targets are what lead to these different side effects. So BCL2 inhibitors, the one that I'm going to shift gears now and talk about BCL2 inhibitors. The main one that we have access to right now is called venetoclax. And venetoclax works so well that it actually kills cells almost too rapidly. And what happens is these cells break open, and when they do, they release their contents into the blood, contents like electrolytes, so potassium and phosphate and uric acid. And these electrolytes can then sort of wreak havoc on the body. They can cause arrhythmias, so they can affect the heart, and they can cause kidney problems. And this is something called tumor lysis syndrome. So to prevent tumor lysis syndrome, the way we give venetoclax has to be given in this stepwise, we call it a dose ramp up, where every week you start at a low dose, and every week the dose gets increased until the full dose, which is 400 milligrams daily. Problem is, every time we have to increase this dose, there's a risk of tumor lysis syndrome. And so we need to do a lot of blood work every time we increase the dose. Sometimes we have to even admit people to hospital to give them fluids and check their blood work even more frequently to make sure there's no tumor lysis syndrome. So, but once people get up to that 400 milligram dose, there's no more risk of tumor lysis syndrome, and they tolerate the drug really well. So I always tell people that venetoclax it works extremely well. It leads to very deep responses, but it really is a commitment for those first 5 weeks. It requires a lot of blood work, a lot of back and forth. Sometimes you do require hospital admissions. So it's a bit more intensive in those first 5 weeks. So putting it all together, just want to show kind of where we've come with CLL treatment over time. So when I first started my training, we were really focused on the benefits of adding rituximab to our standard chemotherapy. And that chemotherapy is generally fludarabine and cyclophosphamide with rituximab. Or in British Columbia in particular, we used a lot of just fludarabine alone with rituximab. We also have bendamustine and rituximab, and then actually a drug called chlorambucil with obinutuzumab. And though we know that adding the monoclonal antibodies to the chemotherapy really helped improved outcomes. But since then, we have this development of targeted agents we've talked about, ibrutinib, venetoclax, acalabrutinib, and zanubrutinib. And these, when they were first introduced, these are all given indefinitely. When they're given by themselves, they're given essentially, people take it as long as it's working, and as long as they're not having side effects. So this is like starting a drug for high blood pressure. You'll probably be on it indefinitely. But now we're really getting into this era of combining drugs together. And because often combining them together leads to much better responses, we actually feel comfortable stopping the treatment after a certain period of time. So we call that time-limited therapy, or you might hear the term fixed duration therapy. So the main ones here are venetoclax and obinutuzumab, which is given only for 1 year. And there's a new one that's just coming out after some clinical trials have reported excellent results, and that's the combination of ibrutinib with venetoclax, which is also given for 1 year. So with so many choices, how do we choose what to give for our patient? So first and foremost, we look at the clinical trials, and we want to look at two things. We look at what we call efficacy, which is how well did it work? How long did people stay in remission? How long did they survive? And we look at safety. What were the side effects? We also, though, look at those prognostic markers that I mentioned to you. In particular, we look at whether people have deletion 17p, and we look at their IGHV mutational status. Then we look at something called fitness, or what we call comorbidities, which is how kind of healthy is a person, and how what other medical problems do they have, which is what we mean by comorbidities. When I say fitness, I don't mean sort of how much can you bench press at the gym. What we're talking about here is, yeah, what other problems do you have, medical problems, other medications someone's on. We do look a little bit at how active or inactive somebody might be. Um, and so it's really the idea here is to base treatment not on an age cutoff, but to base it on a person's overall health. And then really importantly is that we want to know from you and from the patients, what are their values? What are their preferences? We don't always have all options available for each person, but when we do, we need to think about, are you someone who really values your whole idea is I want to get the deepest remission, the strongest treatment. I'm committed to putting in the hard work and the time to get that deep remission, and then to have the sort of longest remission possible. Or do you say, you know what, I live really far from the cancer center. I have a big family. I have lots going on. I can't keep coming back and forth. I want to take something that I know is going to be really good for me for a period of time. I don't mind if I'm on it for a really long time, as long as I'm not having side effects. And, so we really need to get a sense from somebody, especially if there's a desire to sort of have treatment and be done with it versus carry on with a treatment that hopefully is very well tolerated. And then finally, we can't ignore the effects of cost and drug availability. So we live in Canada. We're very fortunate to live in a country with a public healthcare system, but it does put some limitations on the drugs that are available. And, I think we're actually quite fortunate right now that nearly all of the current drugs are available and funded in the provinces. But it is something we need to take into account as well. So where are we heading in the future? As I mentioned, this concept of fixed duration or time-limited combinations of new drugs. There's a lot of clinical trials ongoing looking at using something called MRD to guide therapy, and I'll talk about that briefly. There's new drugs in development, like the non-covalent BTK inhibitors, but there's many more. There's something called BTK degraders. There's other kinds of antibodies. There's other kinds of targets, new BCL2 inhibitors. So there's lots of new drugs in development. And excitedly, we're also moving more into immunotherapy for CLL. And the two main types of treatment here are something called bispecific antibodies and CAR T cell therapy. And I'll tell you, I just came from the international workshop in CLL, our meeting that happens every 2 years. It was just in Boston this past weekend. And the explosion of research and clinical trials is really exciting. And I think we're going to continue to see more and more drugs developed and approved over the next years. So what do we mean by MRD? This is something that's talked a lot about with CLL. So this is when being negative is actually something positive. The idea is that there could be a small number of cancer cells that remain in the body after treatment, but these are not detected by any physical examination, symptoms, or even looking at cells under the microscope. So you need highly specialized tests that can look down to a really deep level, things like PCR and flow cytometry. So when we say that someone is MRD positive, say at the end of their treatment, that means that although everything else might look negative, their scans, you might even do a bone marrow biopsy, there might be no CLL cells. When we do these specialized tests, there are some residual cancer cells. When we say that someone is MRD negative, that means that even looking with these very special tests, there are no cancer cells that we can detect anymore. And we often call that undetectable MRD, or UMRD, is the term that we hear. So I'm going to show this study as an example of a clinical trial that has really is kind of on the forefront of informing how we should be treating patients. It was just published this year in the New England Journal of Medicine, which is really the premier medical journal in the world. And this trial used MRD, so I want to show this trial to you. So I'll just walk you through it. On the left here, you can see that the trial included fit patients. So again, it wasn't based on age, it was based on patients' overall health. And we look at things like organ function, liver, kidneys, other medical problems, other medications that they're on, etc. It did not include people with deletion 17p, and that's because one of the arms gives chemotherapy, and we know that we can't give chemotherapy to people with deletion 17p. And then anymore, now that we have other options. So patients were then randomized, which basically means flip of a coin, and then they entered one of 4 different treatments. And this, I'll really ask you to focus here on the right-hand side. The treatments included chemoimmunotherapy, and this did depend on age, and that's because the approval for FCR in many countries is only for patients under 65 years of age, or they would get bendamustine rituximab if they were over 65. And the bars here just show how long this treatment lasts. So this treatment is given once a month for 6 times, so it's 6 months long. Or they could have been in an arm that looked at the combination of venetoclax with rituximab. So that was the first monoclonal antibody that was developed. And here they get treatment. This is that ramp up that I talked to you about. And then they get treatment at the full dose for 12 months, 1 year. Then the other arms were venetoclax and obinutuzumab, which is a regimen we currently have available in Canada, or venetoclax with ibrutinib with obinutuzumab. So 3 drugs. And their primary thing they were looking at was what was the percent of people who had undetectable MRD at 15 months, so basically at the end of treatment. And you can see here that with chemoimmunotherapy, FCR or BR, the percent who had undetectable MRD at 15 months was 52%. And that's sort of what we would expect with chemoimmunotherapy based on other trials. Interestingly, venetoclax with rituximab didn't seem to improve upon that, but venetoclax with obinutuzumab and the 3-drug combination, venetoclax, ibrutinib, and obinutuzumab, certainly led to significant improvements in UMRD at 15 months. And these translated into longer times in remission. So the patients who got either ven-OB or ven with ibrutinib and OB had the longest time in remission, or something we call progression-free survival. So this trial is really informing how we use these time-limited novel combination of drugs, and is really calling into question whether we should still be using chemoimmunotherapy when we know that these treatments may be better. And so we'll talk about treatment at the end, what's currently available in Canada. The other trial I'd like to mention is this trial, which was also published in the New England Journal of Medicine this year by Anthony Mato from Memorial Sloan Kettering. And this is looking at that non-covalent or reversible BTK inhibitor I mentioned, pirtobrutinib. This is a different way of showing those proteins that the drug targets, but you can see again that the drug really only targets, this is BTK, with very few other targets. So it's more specific to BTK, it has fewer side effects, and the really exciting thing about this drug is that it's effective in cases that have been resistant to covalent BTK inhibitors, which are first and second generation BTK inhibitors. So that means people who've had progression on ibrutinib, acalabrutinib, or zanubrutinib seem to still respond to pirtobrutinib. And that's shown in this plot. We call this a waterfall plot. And really what it's showing is each bar represents a patient. And this here on the axis here is the percent change in the size of lymph nodes in the body. So if people's lymph nodes increased on the study drug, that means they didn't respond. So there were a few patients who did not respond. However, if you look at all the patients who responded, you can see that they responded, there's some that responded a little, all the way to 100% of their lymph nodes completely decreased on this drug. And to me, the really exciting part is that these dark blue lines, these all represent people who'd already been treated with ibrutinib, acalabrutinib, or zanubrutinib, and had progression on those. So this drug, it looks like it will be an excellent option for people who progress on the original BTK inhibitors. And it was very well tolerated with few side effects. These are the common side effects of BTK inhibitors. And for example, ibrutinib normally causes hypertension in up to about 30% of patients, and atrial fibrillation in about 15% of patients. So you can see here the numbers are much lower. So it seems to be a very well tolerated drug. And there's lots of clinical trials investigating this drug ongoing. So the other trial I'd like to mention is this trial, which was also published in the New England Journal of Medicine this year by Anthony Mato from Memorial Sloan Kettering. And this is looking at that non-covalent or reversible BTK inhibitor I mentioned, pirtobrutinib. This is a different way of showing those proteins that the drug targets, but you can see again that the drug really only targets, this is BTK, with very few other targets. So it's more specific to BTK, it has fewer side effects, and the really exciting thing about this drug is that it's effective in cases that have been resistant to covalent BTK inhibitors, which are first and second generation BTK inhibitors. So that means people who've had progression on ibrutinib, acalabrutinib, or zanubrutinib seem to still respond to pirtobrutinib. And that's shown in this plot. We call this a waterfall plot. And really what it's showing is each bar represents a patient. And this here on the axis here is the percent change in the size of lymph nodes in the body. So if people's lymph nodes increased on the study drug, that means they didn't respond. So there were a few patients who did not respond. However, if you look at all the patients who responded, you can see that they responded, there's some that responded a little, all the way to 100% of their lymph nodes completely decreased on this drug. And to me, the really exciting part is that these dark blue lines, these all represent people who'd already been treated with ibrutinib, acalabrutinib, or zanubrutinib, and had progression on those. So this drug, it looks like it will be an excellent option for people who progress on the original BTK inhibitors. And it was very well tolerated with few side effects. These are the common side effects of BTK inhibitors. And for example, ibrutinib normally causes hypertension in up to about 30% of patients, and atrial fibrillation in about 15% of patients. So you can see here the numbers are much lower. So it seems to be a very well-tolerated drug. And there's lots of clinical trials investigating this drug ongoing. So through this greater understanding of the biology and genetics of CLL, as I've mentioned, there's been an explosion of trials with novel targeted drugs. In Canada, we've had 7 new drugs or combinations approved over the last 10 years, which is remarkable, given that before this, we've had maybe 1 or 2 approvals over a 10-year period. And these drugs have fewer side effects. Patients are living longer with longer remissions. So with all these options, how do we choose? So I'm going to show, this is a CLL treatment pathway or algorithm, we call it, that was developed by a national group in Canada that's called CADTH, and some of you may be familiar with CADTH. They are essentially, it stands for the Canadian Agency for Drugs and Technology in Health, and this treatment is available online, it's publicly available. And basically what they do is after Health Canada approves a drug, they then look at all the studies and all the evidence to show that the drug is efficacious and look at the side effect profile and then decide, should we fund this drug in Canada? And they write recommendations to the province of what should actually be funded. So in first-line treatment, these are all the drugs that we have available. And the recommendation from CADTH, and this is where some of my discussion has focused, is that for younger patients with good risk disease, so the ones we know will respond well to chemotherapy, they've recommended FCR. And FCR is an excellent treatment for these patients. If people are not fit for FCR, so meaning they're not able to tolerate FCR, there's other chemoimmunotherapy we can give, or we can give venetoclax and obinutuzumab for 1 year, which has shown excellent outcomes in this group. And in patients who have high risk factors, particularly deletion 17p or unmutated IGHV, that's who they say should be considered for the BTK inhibitors, or you can also consider venetoclax and obinutuzumab in these patients. So I'll just add that in some provinces, even good risk patients who are not fit for FCR, so maybe they're older, or maybe they have kidney problems or other problems where they can't get FCR, we also have BTK inhibitors available to them. And based on the results of the study I just showed you, the CLL13 or GAIA trial, which compared venetoclax and obinutuzumab to FCR in fit patients and showed better outcomes with venetoclax and obinutuzumab, I really think we need an arrow here as well. So now this is looking really complicated. And the bottom line is, in an ideal world, we would have all of these options available for patients. And we can make the decisions based on the things I mentioned in that previous slide, including the patient situation, comorbidities, their prognostic factors, and their preferences, values, what will work best for them. In terms of relapse disease, it really matters what you had in the first place. So most of these treatments will give a remission for approximately, hopefully somewhere between 4 to 8 or more years. But eventually we do expect the CLL to progress and people will need treatment at relapse. So if you've had BTK inhibitors before, then we look to give treatment with venetoclax. And in the relapse setting, it's given with rituximab for 2 years, as opposed to when it's first line, it's given with obinutuzumab for 1 year. That's just based on the different trials that were done. If you haven't had haven't had exposure to a BTK inhibitor, then you can get a BTK inhibitor at relapse. You could get venetoclax and rituximab. And then we do have idelalisib with rituximab. As I mentioned, that one before is not used very often as it has a lot of side effects. And then if people progress again, then we kind of look back. You can use an alternate drug if you've not been exposed to it before. Or this is where we're into the new drugs I've been mentioning, pirtobrutinib, clinical trials, immunotherapy like CAR T-cell therapy. So even with all of our treatments that we have, we still have this risk of something called Richter's transformation. And this is towards the end of my presentation, I just want to end speaking about this. So Richter's transformation refers to when CLL or SLL transforms into a more aggressive lymphoma. And the main ones are something called diffuse large B-cell lymphoma or Hodgkin's lymphoma. And the risk of this happening is approximately 1% per year. So it's rare, but it does happen. And these aggressive lymphomas usually come on fast. People can feel sick from them, but the good news is that they're curable. The trouble is they're not as curable when they are part of a Richter's transformation than if someone just got diffuse large B-cell lymphoma or Hodgkin's lymphoma without having CLL or SLL ahead of time. Especially if they've had prior treatment for their CLL or SLL, it can make it harder to treat the diffuse large B-cell lymphoma or Hodgkin lymphoma. However, there is a lot of research looking into this, particularly looking at the genomics and biology of Richter's transformation in an attempt to look for new drugs and new ways to treat this. The main goal when someone has Richter's transformation is to focus on treatment of the aggressive lymphoma and to try to cure that. So the ways we do that is with standard chemotherapy. So for diffuse large B-cell lymphoma, we use something called R-CHOP chemotherapy. For Hodgkin lymphoma, we use something called ABVD chemotherapy. And we often consider an allogeneic stem cell transplant in people with Richter's transformation, although there are a lot of factors that play into that. But this is where immunotherapy is really interesting because immunotherapy like bispecific antibodies and CAR T-cell therapy are used in the treatment of aggressive lymphomas. So we're sort of borrowing what we know from them from the aggressive lymphomas to use them in Richter's transformation. And again, from the recent IWCLL meeting this weekend, a number of clinical trials were presented with using these agents in Richter's transformation. So a bispecific antibody is an antibody like we talked about before. It kind of looks the same like a Y, but it has 2 targets. And really what it's doing is it's attaching to your CLL B cells, but it's also attaching to T cells. And so it brings the T cells close to the B cells to allow the T cells to essentially exert their effects on the B cells. So the T cells release a bunch of proteins, things we call cytokines, into the blood, and those then go and kill the B cells. Because a T cell's normal job as part of our immune system is to attack foreign invaders, and your cancer is a foreign invader. So this is a way to bring the T cells close to the B cells to kind of kill those B cells. And if there's really a similar premise with CAR T-cell therapy. So CAR T-cell therapy is what we call a living drug. Essentially, again, it's a T-cell based drug where T cells are collected from the patient. They're then genetically engineered in the lab to be able to detect and kill cancer cells. So in this case, to kill the CLL cells. These re-engineered cells are multiplied until there's millions of these cells, and they're basically put into a bag. And this bag is then sent back to the patient, and the CAR T cells are infused, multiply in number, and these attacker T cells recognize and kill the CLL cells. So again, it's a way to get the T cells to attack the cancer cells, attack the B cells in CLL, SLL. There's been clinical trials. This is an example of a clinical trial using CAR T-cell therapy for CLL and Richter's, and all I want you to focus on is the red here and the percentages. These are the percent of patients who have a complete response or in blue is a partial response. So this is the number, if you add up the red and blue, this is the people who are responding to the CAR T cells. And they were just testing different dose levels. So very high rates of response. And here is looking at that goal, which is to get undetectable MRD. And again, in red, this is all the patients who had undetectable MRD in the blood after getting CAR T cell therapy. So it's looking really promising. However, there are risks with immunotherapy, bispecifics, and CAR T cell therapy. Because you're essentially activating the immune system, patients can get something called a cytokine release syndrome. And for reasons that aren't really understood yet, there's a neurotoxicity that patients can get where they have speech problems, confusion, and drowsiness. So we really can't take these therapies lightly. We certainly need more research into them. We know people respond well, but the question is how long will they maintain that response? And we really have to balance the risk of these treatments with the rewards. So this is an area where there's an active area of research currently. So in summary, we've talked about a lot of things in these 45 minutes. I just want to summarize. We've reviewed how CLL is diagnosed in the blood and by flow cytometry. We've talked about the most important prognostic markers, deletion 17p and IGHV mutational status. We've talked about the fact that active surveillance is more than doing just nothing. This is a prime time to have preventative cancer screening, immunizations, and overall health. And we've talked about how CLL research has led to approvals of many novel drugs with fewer side effects, including monoclonal antibodies, BTK inhibitors, BCL2 inhibitors, and then new drugs under development. And finally, we talked about Richter's syndrome, and I just want to emphasize that in the research community, there's currently a major focus on understanding the biology and genetics of Richter's and the development of new therapy. So let's go back to the patient, to the case. So this was the 66-year-old gentleman who had a knee injury. His CBC and flow cytometry confirmed CLL. He was asymptomatic at diagnosis, so I followed him every 3 months for the first year and then every 6 months or so after that. We made sure that his cancer screening was up to date, prostate, colon, sun protection, doesn't smoke, minimal alcohol use, and that the immunizations were up to date, including pneumococcus, Shingrix, COVID boosters, and flu shots. 4 years later, now he's 70 years old, he developed more fatigue, he couldn't run like he used to. He started to get some lymph nodes that were uncomfortable, and his lymphocyte count rose to 150. So this is all pretty typical when CLL patients need treatment. Prognostic markers showed that his IGHV was unmutated, and he had something called trisomy 12. So the key here is that he does not have deletion 17p. I don't have access to TP53 mutation testing, although I would have liked to have done that one. And hopefully we'll have that up and running in British Columbia within the next year. So we discussed 2 options for treatment, well, actually 3. We discussed the second generation BTK inhibitors, acalabrutinib or zanubrutinib, both which would be given indefinitely, so for many, many years. And we discussed the time-limited therapy of venetoclax and obinutuzumab for 1 year. And he really was keen to have treatment and be done with it. He wanted to get back, his primary goals were to get back to being able to spend time with his family and back to the running. So he chose venetoclax and obinutuzumab. In discussions with myself, I thought that was the best treatment for him, putting everything together. And he is nearly finished, tolerating it really well, and he's already back to running. So, my hope is that this treatment will keep him in remission for hopefully 5 or more years. But even when it does progress again, because we know it will, but when it does progress again, we have so many other treatment options available, and I'm really excited about where things are heading in this field. So with that, I'll end and hope to take questions in the Q&A session afterward. Thank you.
Thank you, Dr. Gary, for that wonderful presentation. We appreciate your thorough review in terms of disease biology and treatment options. Now I'd like to direct the audience's attention to attend the Indolent Lymphomas Q&A session after this presentation to have your questions answered live. Thank you.